Welcome everyone to the January 2021 CWIS Case Review Series presentation. I'm really excited. We have two great cases today. Before we get started, I just wanted to remind everyone about the kind of rules of engagement of the Case Review Series. Each speaker will have between 5 to 7 minutes to give us their presentation, and then there'll be 5 to 7 minutes of questions afterwards. I'd ask that you please remember to mute yourself if you're not talking. You'll know you're muted if there's a red microphone with a line through it on the bottom left portion of your screen. Just also a reminder that all of these CWIS Case Review series are available on the CWIS Case Review website. So if you didn't catch some tasty bit of information the first time around, you can always go back and re-review them at your leisure. So I would encourage you to take a look at the CWIS Case Review series website and for all of your interesting case needs. With that, I'm honored to be able to introduce our first speaker. Dr. Long is a retired thoracic and trauma surgeon who really helped develop the processes that we now use to repair chest wall injury. So it is a true honor to have him here today to present this case. And with that, I'll hand it over to you, Dr. Long.
Okay, thank you very much, Joe. Appreciate it. So this case was a real challenge. I had not had any experience with something like this before. He's a 27-year-old male in a domestic dispute, which resulted in a self-inflicted shotgun blast to his left chest. It was a 20-gauge shotgun short barrel with a lead slug normally used for shooting coyotes. The blast lifted off the skin and subcutaneous tissue over his left pectoral muscle, just above and lateral to his left nipple. The impact of the slug basically hit the third rib and went down at the angle that would destroy the fourth to the eighth rib, giving a blast injury to the left upper and left lower lobe, creating a sucking chest wound, and there was no exit wound. You'll notice from the picture on the slide that you can see the lead slug and the entry wound on to the left of his sternum, and that went through the slug went through the inferior aspect of his scapula. Can I scroll this or not? All right. So his he was taken directly from the scene of the accident, and about 10 minutes pre-hospital care time went directly to the operating room as per our protocol for unstable patients. And he basically had 2 chest tubes put in initially, and there wasn't much blood coming out. He got intubated, and then one of my colleagues, Dr. Arvin G., and the other one, Melissa Barney, came in to sit there and deal with initial injuries. And he started bleeding from his left chest tube and bleeding in the tracheobronchial tree. They did a left anterior thoracotomy, removal of the shotgun wadding in the left major fissure, and a wedge resection of his left lower lobe, and stapled that. He had blast and shrapnel injuries of the left lower lobe, consolidation, and massive hemorrhage occurred during the wedge resection of his left lower of his lingula. And they did massive transfusion. He had a PEA arrest, they had pericardiotomy, found no blood within the pericardium, did open heart massage, and he came back with successful resuscitation. Next. I can't. All right. So his postoperative course, he had a complete whiteout of his left chest, and a lot of his right chest from bleeding the tracheobronchial tree with blood clotting both sides of his tracheobronchial tree. So we felt that in view of this, that it was heavily contaminated wound, that he was not a candidate for immediate fixation of his ribs, and we would focus on trying to get his lungs function improving. He had an FiO2 of 95% with PO2s in the 60s. So we initially treated him with his profound hypoxemia with proning, VDR, or the volume diffusive respirator, developed by Forrest Bird, who also had his own, in my early days, a little bird respirator, and serial bronchoscopies to keep the tracheobronchial tree clear. So what you're seeing is a CAT scan of his lung windows about 24 hours after VDR, proning, and bronching, and it was remarkable clearing of the right side, which was not injured. The left side, the left upper lobe, cleared rapidly, but he did have consolidation of his left lower lobe, and we were wanting to get his lung function better before we would put him under another anesthetic and in the operating room to fix his chest. Next slide. So, but 3 days later, I did a left lateral thoracotomy with him in the right lateral decubitus position, taking the incision from his mid-axilla down to his left eighth rib, and basically was able to spare the latissimus dorsi, which was uninjured, and pull that posteriorly, and then expose his rib cage by also raising the serratus anterior muscle off of its origins on his ribs, and then moving that posteriorly as well. That gave us a good exposure of his rib cage. And then the question was, well, what to do? After removing all the non-viable tissue, he had no bone fragments that was large enough to try to do a repair with, and his intercostal muscles were non-viable. All that was debrided. So then the question was what to put in the big gap. Some people would put methyl methacrylate plates in, methyl methacrylate in, but that's, in a contaminated wound, that didn't seem like a good idea. Others might put a mesh in, but that's still going to give him a flail chest, a sizable flail chest. So we took the chance of putting in titanium pre-contoured rib plates with screws anchored on each end, 4 screws on each end, spanning this 8-centimeter gap between for the 4th through the 8th ribs. That gave the stability that we were looking for, and then we put a vicryl mesh underneath of that so that the flaps that we had created would not go through and basically stick to the lung, try to recreate a parietal pleura with the vicryl mesh. We closed the chest with sequentially with muscle flaps for the hardware coverage, used wound vacs and further drains between the muscle layers to sit there and facilitate the recovery without trying to get it infected. Next. So this is a chest X-ray, basically 7 months after the injury, and we were surprised that the plates would last this long. He had it was a dictum of orthopedic surgeons who I worked with to develop a rib plating system with that for non-unions, you had to have the bone edges approximated. So having an 8-centimeter gap was considerable worry, and I was prepared that he would fracture, expected him to fracture his plates, one or all, sometime in the post-operative period. We put him through extensive physical therapy, and then over the period of time with physical therapy, he regained normal chest wall mobility. I was able to bend over and touch his toes, lean to the right and left 30 degrees, twist his torso 15 degrees, and he got 90% of his pulmonary function restored. He went back to work. He still remained connected with his girlfriend, and I wanted to follow him up further, but he refused. On about the 6th post-operative day, I finally twigged on that he might get lead intoxicity, and so we measured his serum lead levels, and they were markedly above the normal range. And so I plate treated him with Suxmer for about 2 months, and did not try to take all the small bone lead fragments out, assuming that the Suxmer would take care of that, and we would not have to do repeated thoracotomies to try to find these small fragments. So the learning points were, this was a contaminated wound, which we thought precluded immediate fixation with rib plates. We wanted to evaluate the extent of the lung injuries to determine if there was need for further pulmonary resection at the time of the rib reconstruction. And we basically felt that flexible titanium plates could be used successfully to span significant gaps, but this would be the first reported case that we knew about. And we found there were no plate fractures during the 4-year follow-up and a long-term outcome with no disability. And we, I guess, twigged on to the use of chelation therapy for elevated serum lead levels when we considered that we knew about we lead levels rising with lead fragments, soft lead fragments in joint cavities where they had corrosive fluids. Any questions?
Well, thank you so much, Dr. Long, for that great presentation. To all the people who are viewing out there, please feel free to put questions into the chat. I'm going to stop sharing the screen here real quick. One question that I had, Dr. Long, you had mentioned the large gap that you had between the rib fragments, and that this was kind of the first case that you had used or had used a titanium plate to span that gap. Since this case, have you had any other cases where you've used the titanium plates to span such a large gap, and what has been your experience?
No, I had not. For some of the non-union cases, contrary to John Edwards' experience, our orthopedic surgeons always insisted that even though there was a gap, that had to be closed and you had to rely on proximity. So we did tighten the chest wall by trying to approximate ends of ribs where their non-union had occurred. And that was my experience. I had nothing to contrast that with until I heard about Dr. Edwards.
And it looks like Dr. Edwards just mentioned that we do get plenty of shotgun wounds here in the UK, but not so many gun injuries. He isn't aware of lead chelation therapy, and he was asking if you could potentially recommend the name of the drug that you recommend for the chelation.
Pardon? Your voice is a little unclear to me.
Dr. Edwards was asking about what drug you used for the chelation therapy.
It's called Succimer, Succimer. It's a chelating agent for lead.
All right. Do you have any other questions from the chat? One additional question that came up yesterday when we were going over the slides was the ventilatory strategy that you used. I think not everyone on the slide will be, or not everyone on the show will be, well, necessarily understands what the VBR is. If you'd be able to talk a little bit about that.
Well, the VDR has been around quite a while. Some of you are old enough to remember invented that little small ventilator pressure cycle. He continued on with his works on trying to ventilate, and in fact got a national award for creating a respirator that would work for high altitude. Volume diffusive respirator, which is very different from the high frequency oscillator. He was able to humidify, which the high frequency oscillator does not do, and he was able to. You were able to sit there and ventilate almost with a Venturi effect to get air going down the center of the tracheobronchial tree, and then the fluids and the other material, ash or whatever from burns, would come back. Burn scarred would come back the other way. We didn't know anything about it until the burn surgeon started using it for smoke inhalation. As many of you know, smoke inhalation causes a huge exudate, can cause a huge exudate in the tracheobronchial tree, and they get a lot of atelectasis distal to that. And they noted that with using that technology, they could get ash back out of the tracheobronchial tree when they couldn't get it out by bronchoscopy or trying to clean the tracheobronchial tree. So we started using it for bad pulmonary contusions at low positive end expiratory pressures, about 5, and the lung contusion healed quite quickly. So when this came up, we were concerned about, since there are multiple holes from fragments going through the lung tissue, that whether or not we would make the matters worse by using APRV or other respiratory techniques, and we tried it and it worked.
Excellent, thank you. There's another question from Dr. Meshkin, and he was asking if you could expand on how you use the mesh during your reconstruction. I think it was Vicryl mesh that you had placed.
Yeah, we basically take a sheet of Vicryl mesh, put it underneath of the rib plates, and then sew the mesh to the rib plate, and extended it laterally to both anterior posterior axillary lines, upwards as far as the 3rd rib, down to the 8th rib, and that we thought we basically, with the muscle flaps over top of that, he might end up with a renewed pleural cavity. We did not want a lot of extensive scarring. We did not want to have fibrosis of the visceral pleural of his lung, and we thought this was done. I've used that before in chest cases, cancer cases, and so on, and it's worked quite well.
Excellent. Thank you so much again, Dr. Long, for your presentation. We really appreciate you taking the time to present your case here at the CWIS Case Review Series. With that, I'm going to bring up Dr. White's slides here. And can you see the full screen slides?
Joe, we're looking at the sorter view or whatever. It's not the full slideshow view.
Okay, give me one sec. All right. How about now?
There it is. Terrific.
Before you get started, let me briefly introduce you. Dr. White is a trauma and acute care surgeon at Intermountain Health. He's also the chair of the education committee and has certainly been a mentor to me as I've been working through building up my chest wall practice. So it was with great honor that I hand the case review series over to Dr. White to talk with us a little bit about calf wrestling.
Thanks, Joe. Good afternoon, everyone. And a special welcome to two of my friends from across the pond, Dr. Moheb Rashid from Sweden and Dr. John Edwards from the UK. Thanks, guys, for staying up late. I see that John's got a little liquid refreshment there to help with that. So thank you very much for this opportunity. Let's just get right into this. Let's go to the next slide, please, Joe. So this is a case that I encountered a couple of years ago, about 4 years ago now. She was sent to me by a former colleague and partner from my former practice in Western Nebraska. This woman was a 46-year-old female cattle rancher who, in some way or form, which I don't really understand, she was a calf tried to climb into the cab with her as she was tagging the calf or doing something, or it could have been the mother that tried to do it. I'm not sure, but in any event, some sort of bovine animal came into the cab where she was sitting and pushed her to the right, where she encountered the either the opposite seat or the console, and she had immediate pain in her upper right chest in the infraclavicular area anteriorly, which persisted unabated despite analgesics and rest and physical therapy for about 11 months, when she was finally evaluated with a CAT scan, which showed this abnormality in her at the junction of her right first rib and her clavicle. I describe this as a first rib non-union, but it's probably more accurately described as a sternocostal synchrondosis. Like I had to look that up. But the compelling thing that led me to believe this was real pathology was that there was no corresponding lesion on the left side, and it was exactly where her pain was. And even though it doesn't look like a hypertrophic non-union that we classically see in the ribs, there are descriptions of first rib non-unions, although they're rare. And the largest series come from Japan, where kids throw baseballs side-armed and incur injuries. Those fractures of those non-unions are typically more lateral, but usually these are treated with, if they're going to be treated surgically, they're treated with a resection arthroplasty. So when I saw this woman, I felt compelled to offer her a plating procedure. I felt like that might be a less invasive operation than to resect her first rib head and lateral sternum. And so we had the luxury of some time. I met her and then had a couple of weeks before her surgery was scheduled. So I enlisted the help of my biomedical engineer, Dr. Rami Short, who's on the call today. Maybe he can answer some questions if you guys have technical questions about how this 3D imaging is done. But Rami, welcome. And we printed 3D in full scale this woman's clavicle, lateral sternum, manubrium, and first rib complex, which then allowed me to fashion a rib plate at my desk at my leisure. It took about an hour and a half to complete this bend. I didn't want to overbend and have to bend back, so I was very deliberate and slow about it. But you can imagine that this complex shape would have been very challenging to do in the operating room in situ. Much easier at my desk and more fun, and didn't waste OR time doing this. So we sterilized this plate. Next slide. And we went to the operating room, and through a infraclavicular incision, transversely oriented, we exposed the first rib and the lateral sternum. Here's a picture of that exposure. It was really quite straightforward. And then the plate matched the patient's anatomy precisely and simply required drilling and placement of 7 screws. I put 4 screws in the bony rib laterally and three screws in the manubrium. You can see the construct here. Simply close that in layers. Next slide. No chest tube, and the operative time was 47 minutes. And I'm not super fast, so it really was that straightforward. This is her post-op photo of her wound. You can see her chest X-ray there, and it's really I'm not being not Pollyannish about this result. She just really had she never turned a hair, and she had immediate relief of her pain, which was terribly gratifying. And then she has remained free. I called this nice lady 2 weeks ago just to get the most recent follow-up I could in anticipation of this presentation, and she remains symptom-free. She had some soreness for a few weeks, which responded to Tylenol, but she never used any narcotics, and she's back vigorously working as a rancher with her family on a cattle ranch in western Nebraska. So I feel like this case was, I think this is a win. It's a novel way to repair a first rib non-union. It's not been described in the literature. A plate fixation of this pathology has not been described. And I think the learning points here from my standpoint are that the distal first rib exposure is relatively straightforward. It's not through the axilla, not through the supraclavicular fossa, but just beneath the sternal head, and it's actually pretty straightforward and can be done by anyone. 3D printing is something one should consider if you have this technology available to you and you have some way to pay for it. You can recreate the anatomy precisely from their CT scan images and pre-bend their plates, which saves time and allows for a very precise matching of your plate to the rib and sternum. Non-unions can be plated in situ. I think we've known that for a while. Dr. Edwards has certainly spoken to this issue before, probably has the most experience doing that. It's not our usual course of dissection or mobilization on more distal ribs, but in this situation, it seemed to be the proper thing to do, and so far we've gotten away with it. So I welcome any comments or questions that you might have. Thank you very much. Well, there have to be some questions. It's not that straightforward. Oh, I'll pull up the chat. Okay, here we go. Okay, so from John Edwards, quite often I believe that I see what appears to be air inside the first chondrosternal joint. Am I imagining that, or have others seen that too? With a lot of bending, do you have problems with screws not locking? John, I have had, well, I'll answer the second question first. I have bent plates vigorously enough at the orifice of the screw, or at least the hole, which has created problems with screw locking. I attempted to avoid that, and that was part of that slow, precise, incremental bending process. As I wanted to stay away from the holes as much as possible, and I did not encounter any locking issues with this particular bend. It does look like air in that space, and I don't know if I'm looking at the joint. There was no corresponding air-filled space on the opposite side. So I took this to be pathologic. I don't have, I have no way to prove that except for her clinical recovery, which suggested that this was pathologic.
Congratulations for such a great job, Dr. White.
Thank you, Moheb.
This is terrific. This is the first time to hear about it. This is a unique case. Congratulations.
Thank you very much.
You're welcome.
John, do you have any comments? You'll have to unmute.
Apart from me asking how your case is from the weekend, so no, I think the use of 3D printing of complex anatomy is the other very interesting point for this. And I mean, I'm gaining experience locally now of dealing with non-united sternotomies, and I've got some very, very complex reconstructions coming up, and that's also from pectus surgery that's gone wrong. So I've got a patient that's had a pectus carinatum repair about 12 years ago and has had, I think, 7 operations by various surgeons where they have taken away more and more ribs and more cartilage and made the anterior chest wall more and more unstable. And getting a 3D printout has really meant that I can get my head around the repair that we're going to have to do. I haven't got as far as bending metalwork at my desk, but I can really see how you're right. I think if you can take your time, you can make the bends away from the screw holes, bearing in mind I'm likely to use the same manufacturer as you did there. So I think that for these complex reconstructions is a really good tip, and I'm sure that many of us will look to use that when we can.
Thank you, John. I think I would suggest, and see if you agree with me, that if you're gonna go down this avenue, choose an easy case first. Maybe even just a grossly displaced fracture or a non-union to play with. And don't choose that case that has 5 or 6 overlapping fractures and with where the anatomy is extremely hard to recreate. Although one thing to keep in mind is if you need a template for your plates so that your plates are the right shape, even though your CAT scan doesn't show the rib that you want to match, you can mirror image the opposite side. And we've done that a couple times now. So just have your 3D modeler reverse the image and use the left 7th rib, for example, as your template for your bend if you're going to use it on the right side. That's a tip that one could certainly utilize. I don't see any other questions. Dr. Forster just messaged me that his Zoom dropped out, so I will bid everyone adieu, and I thank all of you for your attention, and we'll see you next month. If you have any interest in presenting a case, just contact myself or Joe Forster or Sarah Ann Whitbeck, and we'll get you on the schedule. So thank you all.
Thank you so much. Thank you.
Bye-bye.
Good evening, everybody.
Thank you.
Bye-bye.